My name is Sam Siegel, and I'm a mom of three and a physician, internal medicine, an avid jogger, and somebody who generally lives a very healthy life and enjoys life, which is why I was pretty shocked to get diagnosed with Hodgkin's lymphoma sort of on the eve of my 38th birthday. And that's got a pretty high cure rate of about 90%, especially if you go through with the recommended chemotherapy, which I did. So I took 6 months of the standard chemotherapy regimen called ABVD, but I completed all 6 months and had a scan shortly after finishing that um, that declared that I was in remission. I had no evidence of disease and what some people would even consider cure. But I really wasn't feeling well when I was declared in my first remission. I sort of felt that even though the scan was clean, that I wasn't feeling right. Ultimately, I had to get a chest surgery to get a lymph node right near my heart in order to get diagnosed with the relapse. So once that was diagnosed, I started a new chemotherapy, or what's called targeted therapy. It's kind of like a smart chemo. It's been an incredible journey from doctor to patient, and pretty soon back to doctor as I start easing back into practice towards the end of my maintenance chemotherapy that I'm on post-transplant. But it's taken a long time to recover and to sort of evolve as a person and make meaning of this experience and make sense of it. And the first round of this, I just kind of felt victimized by the whole process, and that I was sort of diagnosed, and that if I just did what the doctor said and followed through with everything, it would be a nuisance of 4 to 6 months and I'd lose my hair, but it'd be cured and I'd never hear from the thing again. And then when it didn't work out that way, I sort of began to see it as something differently altogether, that this cancer, I choose to believe that this cancer came into my life as an opportunity to learn about my health and my well-being, and about setting realistic goals and expectations for myself, about taking care of myself and making a space for my own self-care. That's one of the main reasons why we're having this conversation today with top Hodgkin lymphoma specialist, Dr. Matthew Matasar from Rutgers Cancer Institute. We can learn what are the most up-to-date treatments, how should patients be thinking about Hodgkin lymphoma in this new era of immunotherapy and all the new therapies that are offered. The landscape of treatment has really changed in the last 10, 20 years, and that's after there were decades and decades of very little change in Hodgkin's treatment. So I think it's a really hopeful time and a really wonderful time to be having this conversation. Can you tell us a little bit about your journey into medicine, and then how you became interested specifically in blood cancers and lymphoma?
So I went to medical school with the intention of being a philosopher, a medical ethicist for like a job. And it just turned out that when I got to medical school, there was like this whole patient care thing and this whole like research and science thing. And it turned out to be super interesting and fun and richly rewarding and hard. And I was hooked. My thinking has always been like, I want to be somewhere where what I'm doing matters, and where if you're good at it, it really matters. Like make the world a better place in some small way. And that led me to cancer medicine, to oncology. And then I was introduced to the field of lymphoma by wonderful mentors. And I was overwhelmed by how little I knew and how little we knew about this and these diseases. And I was like, yeah, I could imagine doing this for 30, 40 years, and I still won't know everything I want to know, but maybe I can make a difference and help a couple people along the way, and I'll never be bored. And here we are.
Great. So you are at ASH, the annual conference, and I guess we'll get started by just, do you have any sort of hot off the press kind of new announcements in Hodgkin lymphoma that are fresh on your mind that you'd like to share?
What I would say is that we continue to learn how best to use our best medicines in treating patients with Hodgkin lymphoma when they've been newly diagnosed, as well as when unfortunately their diseases come back despite receiving good treatments. There's a lot of question in my world about what is the best way to treat patients when they have a new diagnosis of Hodgkin lymphoma. It's what somebody once called for me, it's an embarrassment of riches, right? We have all these good medicines, all these good chemotherapy programs, targeted therapies, novel therapies, immunotherapies. We have all this stuff. We have all these tools in our bag, each of which has good effects in terms of treating or hopefully helping to cure a Hodgkin lymphoma, and each of which has bad things about it, side effects, risks, toxicities, things that it does that hurt people. And how do we mix and match all of these tools to come up with the best approach for an individual person? How do we personalize that approach? And how do we tailor it so that we're maximizing the chances of cure and at the same time minimizing short and long-term risks of treatment? This is the holy grail of Hodgkin lymphoma, right? How do you maximize cure and minimize risk? And we have some good insights this year in Hodgkin's and continuing to move that forward. There's long been this understanding that immunotherapy, right, treatments that harness the immune system to kill cancer cells instead of just poisoning them with chemotherapies, that these immunotherapies are very powerful treatments of Hodgkin lymphoma. We know this. And there's many of these treatments that are already FDA approved to treat Hodgkin lymphoma when it's come back after traditional treatments have failed us. A lot of us want to figure out how best to use those medicines for patients before their lymphoma comes back, meaning how do we use those to cure them the first go around? There's a lot of different ways that you can imagine doing that, right? You can imagine we're going to use these medicines in everybody who's diagnosed with Hodgkin lymphoma. If you have a little bit, if you have a lot, if you have early stage, if you have advanced stage, if you have bulky disease, meaning a large lump of the stuff, if you don't have bulky disease, maybe everyone should get immunotherapies. Maybe nobody should get them. Maybe only people with high risk disease should get them. Maybe we should only use them when treatments look like they're not working as well as they should. So we're continuing now to get first look at a lot of the clinical trials evaluating using these immunotherapies as in combination with chemotherapy for patients with newly diagnosed Hodgkin lymphoma with the intention of trying to maximize cure, minimize risk. I would say the data this year at ASH are a little bit of a mixed bag. We see very good success in terms of getting patients into remission by combining chemotherapy and immunotherapy. And we also see that incorporating immunotherapy into treatment programs for patients with Hodgkin lymphoma come with a price. And I don't just mean financial price, I mean, they come with risk. And we see that patients that are treated with these immunotherapies, one of the things that immunotherapies do is they activate the immune system. And when your immune system gets activated, that can cause trouble, because that activated immune system can then actually act against your body and can lead to immune reactions where the immune system is injuring healthy parts of your body and causing lung inflammation, causing inflammation of your intestines or inflammation of your skin, or even, vital organs like your heart. So we have greater insight now into that risk-benefit profile, the risk balancing of using these treatments in patients with newly diagnosed Hodgkin lymphoma. My read on the data, for what it's worth, is that we're going to need to be a little bit choosier in who we use these powerful but not without risk treatments. And it shouldn't be a one-size-fits-all approach. I think that's the wrong way to do it. And I think that the data at ASH support that. They show us that if you use it as one-size-fits-all, you're going to lead to side effects that maybe were avoidable. And instead, we need to be a little bit more nuanced, a little more subtle, a little smarter in picking who we think need these treatments in order to achieve their cure and not have to go through the rigors of the treatments that we use to cure this disease when it's come back after good first treatments.
Could you tell us just a little bit more about how traditional chemotherapies work, and then how these immunotherapies work, and how the sort of safety profile and side effect profiles kind of compare with the two therapies?
Yeah, and we can do that maybe just by taking sort of a little bit of a walk back and looking at how the treatment for Hodgkin lymphoma has evolved over these last few years. Since I was back in medical school when I had some hair, the treatment back then was ABVD chemotherapy, ABVD, 4 medicines, each one a different chemotherapy medicine given in combination. These medicines given by vein every other week for some number of months, up to 6 months in total. And this treatment cured many, although not all patients. We always wanted to do better, and we knew that ABVD chemotherapy has side effects, and particularly that B in ABVD medicine called bleomycin, and that medicine is well known for its risk of potentially causing lung injury, which obviously is not anything that we ever want our patients to experience. So we've been trying to get rid of that drug, and a very important clinical trial was conducted globally that goes by the very odd name of Echelon 1. This was a large randomized clinical trial, so patients around the world with newly diagnosed Hodgkin lymphoma, the great computer in the sky flipped a coin. If it came up heads, they would get ABVD. And if it came up tails, instead of the B, they would get a new medicine called brentuximab vedotin, or BV for short. And that would get switched out instead of the old bleomycin. And it compared this new AVD plus BV compared to the old ABVD treatment. And we learned finally over these last couple of years that patients who get the new treatment with that new BV medicine are more likely to be cured and live longer than patients who received the traditional ABVD treatment in that study. So that was a landmark event in my world, because it tells me that I now have a better tool to cure more people and help them live longer than I could before, which is all we ever want. So that moved us forward. Now we have AVD-BV as our new and improved standard treatment. And then the question is, can we do better yet? And can we then incorporate things like immunotherapies on top of that? So many people are looking at saying, okay, well, can we add immunotherapy onto AVD-BV, or switch one of those drugs out and add an immunotherapy? And can we continue to ratchet up the sophistication of our treatment to cure more people and help them live longer? We don't yet know. That's the work that's ongoing. My hope is that we will be able to cure more people using immunotherapies the first go around, but we need to figure out who exactly are the patients that benefit the most, who need it the most, as well as who's more or less likely to have side effects from these medicines, which we always try to avoid.
And how are those medicines sort of given? Would that look like an infusion every couple of weeks, sort of like ABVD and things like that?
In some ways, logistically, and the patient experience is kind of similar, whether you're getting ABVD, ABD-BV, incorporating immunotherapy. Typically, what this looks like is you come on in, you see your doctor or his or her team. They check you out, make sure you're doing okay. They check your blood, make sure everything's going copacetic. And then you would get your treatment, which is given intravenously, either putting in an IV into a vein, typically in the arm, or sometimes patients need to have some way to give the medicines intravenously safely if they have trouble getting IVs. And that can be some form of a catheter, which is a tube that goes into a blood vessel in the chest, or what's called a Mediport, which is a little button that gets put under the skin of your chest with a little tube that goes out the back into the blood vessels in the chest. So the medicines are given into the veins, whether by an IV or by other means. And typically these treatments are given every other week. So you come in on a Thursday, and then 2 weeks later on a Thursday, you come back and get your next treatment. And for patients with advanced stage disease, as many patients have, treatments are typically given for 6 months or 6 cycles or 12 treatments, however you want to kind of parse it out. But that's often what patients can expect to experience.
You kind of touched on the staging of things, and I think that's a really important clinical point for patients, because you mentioned that we're trying to individualize treatment for Hodgkin's patients based on their kind of risk of relapse and their age and their underlying health. And so there's terms going around like early stage but unfavorable and versus later stage, and like, what does that mean? There's a couple different classification systems.
So the first thing to say is that for a lot of cancers, stage is king, right? You get, cancers that start in an organ in the body, start in your breast or your colon or your prostate or some part. Stage is oftentimes the most important thing about what this is going to look like for you, what's your experience going to be. The point of staging, and staging is just fancy doctorese for describing where in the body is the cancer. And stage 1 means it's in one lymph node or one lymph node area. Stage 2 is in a couple lymph node areas, but all on kind of one side of the body. We think of the diaphragm as like the Mason-Dixon line for the body. And if it's on one side of that, then it's, or it's on the other side. If it's on both sides, then that's called advanced stage or stage 3, lymph nodes above and below the Mason-Dixon line. Stage 4 is just means it's not only in lymph nodes, it's in lymph nodes and something else in your body. That something else could be an organ like your liver or your lung, but it doesn't really matter what it is. Stage 4 just means lymph nodes plus something else. When some types of cancer, not named Hodgkin lymphoma, have spread into other organs, that's a very different situation from where those cancers start. Hodgkin lymphoma is a lymphoma, a cancer of lymphocytes, of immune cells. So this is a cancer that comes from and is of the immune system. Your immune system is by its nature through the whole body, so it shouldn't be a surprise if these cancers show up in more than one spot in your body, and it doesn't have anything to do with whether or not that illness is curable. Stage is important, not because it says who can be cured and who cannot. It's important because it tells us sort of how hard we got to work at this. Patients who have less disease, it won't shock you to hear, generally need less treatment to achieve their best chance at cure. Patients who have more disease will often need to receive a more comprehensive course of treatment in order to give them the best chance of achieving the cure, which we not only know is possible, but we usually expect to achieve for our patients with newly diagnosed Hodgkin lymphoma.
And where do PET scans fit in there? There's this kind of idea or concept about PET adapted therapy, or getting your PET scan kind of when you start and then getting a PET scan after you've had some treatment, and then using that to kind of tailor the treatment as you go. So what does that mean, and how can that be used?
Such a good question. So first, what is a PET scan? That's a good question. Thanks for asking. So a PET scan is a type of body scan, a type of way of taking pictures of inside the body, like a CAT scan, where you will often use medicine that lights up the blood vessels so you can see what you're looking at, very clear black and white pictures. A PET scan is more like an Andy Warhol painting. It's very bright, vivid colors, and you get a lot of information about what's going on. What lights up in a PET scan is metabolism. It's what parts of your body are actually using sugar for energy. And the more sugar that it absorbs, that sugar then is actually a little bit radioactive, and it glows for our cameras. Not radioactive in a dangerous way, but radioactive in I can take pictures of that kind of way. So by doing a PET scan, you can see what areas in the body have unusual or abnormal metabolism. And we know that Hodgkin lymphoma is a very metabolically active thing. Those cells are using lots of energy and doing their thing, so they light up very brightly on a PET scan for me to look at. So by doing a PET scan, I can see where those areas are that are lighting up that shouldn't be lighting up. And that is really how we best stage our patients. It's the best look at where the cancer is and isn't at the start of treatment. Your question was also, how do we use PET scans not just for the staging process, but how can we use it along the way to inform what we do together to try to treat the lymphoma successfully? We know that many patients with Hodgkin lymphoma will have very quick improvement of their PET scans, even after only like 2 months of treatment. So oftentimes that PET scan, even after just 2 months or 2 cycles, 4 treatments, after just that little bit of treatment time, their PET scans will often be already normalized, meaning that if the scan was that good at the end of treatment, you'd say, congratulations, you're in remission. That's often our expectation going into treatment, that the scans should get that much better that quickly. Back in the olden days, when we were doing ABVD chemotherapy, I've already mentioned that bleomycin medicine can be hard on the lungs. And we know that the more bleomycin we have to give our patients, the more risk there is of causing lung injury. So we used the PET response adapted approach, meaning we would do treatment for 2 months and we would do a PET scan. And if that PET scan was already looking great, yeah, awesome, we're on the right track. Let's not give any more bleomycin. Let's take it easy on those poor lungs and just do a VD, no more BE, and finish the next 4 months for 6 months of total treatment, but no more bleomycin to spare lung injury. We're not doing so much ABVD anymore. We're doing a lot of BV-AVD. We don't have the same approach right now in terms of tweaking our treatment along the way based on that PET scan that we do after 2 months. We still tend to do it because we think it gives us pretty good predictive power in terms of how things are going. And there are situations in which that scan after 2 months may be so spooky looking to us that we may recommend moving to an even stronger chemotherapy program in order to try to make more progress. That question of whether we should do risk-adapted intensification of treatment, 2 months, not such great news so far, kick it up a notch, is still, I would say, an experimental approach. And we continue to see data emerging at ASH and other congresses as people look at new ways of trying to address people who have an unfavorable or worrisome scan after those first 2 months, and to try to make more headway.
Thank you for that. Where does radiation fit in all this? Are we even doing radiation anymore for Hodgkin's?
Say that radiation therapy is still absolutely an important treatment modality that we have in our pocket in the treatment of Hodgkin lymphoma. And if you want to be rigorous about it, and we like to be rigorous, we would say that radiation is the single most active treatment in the treatment of Hodgkin lymphoma. It's the thing that you can do that is most guaranteed to get a quick response when you need it. But you're absolutely right. We are using radiation therapy a lot less than we have in months, years, and decades past. And that's because of this balance that we're addressing of trying to maximize cure, but also minimize short and long-term risks. We recognize full well that radiation therapy, as effective a treatment as it is, carries a long-term risk for some patients, depending on where the radiation therapy is delivered. Chemotherapy goes through the whole body, right, from your nose to your toes. So it can affect the whole body in terms of the side effects. Radiation therapy is a focused treatment on a certain area, and wherever the beam shines is wherever is being affected. If that beam shines on healthy tissues, there's a risk of causing injury to those healthy tissues. And radiation therapy for Hodgkin lymphoma is well known for carrying certain important risks depending on where that beam may shine. The most important ones that we consider are, what if that beam is shining on breast tissue? And we know that particularly in younger women under the age of 35, definitely under 30, that if radiation therapy touches breast tissue at that young age, that it can confer an increased risk later in life of developing breast cancer. And the last thing any of us want to do as doctors is to give treatments that put our patients at risk of other cancers later in life. It's very challenging. Do we sometimes use it anyways? Yes, if you have to. If it's that or the Hodgkin lymphoma is presenting a peril to life and limb, then of course you have to do what you have to do. And then you are talking about how do you apply good survivorship care after their Hodgkin lymphoma has, God willing, been cured, to work to protect and safeguard a patient's health in the months and years to come.
Absolutely. And you just touched on one of my next questions, just about survivorship and some of the most important issues that survivors are facing in the long term. Because the good news is, like you said, most patients with Hodgkin's will be cured. So then survivorship really becomes kind of a really, really important issue for the decades after, patients are cured of their Hodgkin's. And so what are some of the top things in your mind, in addition to the potential injuries to the tissues or secondary cancers that patients may get from having had the treatment?
The first thing I would say is that the most important thing to remember for patients and their caregivers is that survivorship care is cancer care, and that everybody who's gone through a journey with Hodgkin lymphoma deserves to receive compassionate, thoughtful, wise survivorship care as they survive and live with their history of Hodgkin lymphoma. That's not to say that everybody's risks of having problems arising from their prior Hodgkin lymphoma and its treatments is equal. We know that's not true. But everybody should be able to generate what's called a survivorship care plan, which is simply an easy, straightforward document that says, this was my diagnosis, Hodgkin lymphoma. This was the treatment that I received, which medicines, which doses, how many rounds or cycles. Did I need radiation therapy or not? If I did, what tissues in my body were touched by the radiation? And then what are the recommendations from my oncologist and their team regarding my care going forward? What do they think I need to do to be able to safeguard my health the best? That simple document can then go with you, whether it's a digital document in your electronic medical record, or whether it's something that you simply have in a file at home that you can then share with your other doctors, your primary care providers, your other providers, so that everybody's on the same page. Everyone understands what you went through and what everybody should be attentive to protecting your health going forward. What goes into that in terms of what to do and what we advise our patients in terms of safeguarding their health depends on the treatments that you received and understanding the risks that are associated with the various treatments that we give. So for people getting a BVD or BVAVD, the A in that program is a medicine called adriamycin or doxorubicin. That's that red medicine. And we know that that medicine carries a risk of some small magnitude, but not zero, of increasing the risk of heart problems later in life. So people that get these treatments should have attention to their heart health in the years and decades to come. How much do we need to scrutinize the heart health? How often do we need to do testing and what types of testing varies from person to person based on how much of that medicine you needed and how healthy are you otherwise? Do you have other heart health problems or other medical issues that may complicate your heart health? So that can be personalized in a survivorship care plan. And if there's complex needs, then people can actually get that care at survivorship clinics, which increasingly exist in the context of cancer centers, where our patients who are survivors at highest risk for complications from treatment can be followed in a multidisciplinary, thoughtful, data-driven way so that we can really do the very best job at protecting our survivors' health.
I love that. I love that. I think that message is super hopeful. And sort of the last thing I wanted to ask about was for the relapse refractory group, which is a small subset of people in Hodgkin's, but my understanding from what I read of the abstracts at ASH this year seem hopeful, even for patients who relapsed after having had transplant. And that's really exciting for those of us who've already relapsed once.
You're absolutely right. And we've made such great strides in the treatment of patients, few though they are, thank God, who have their lymphoma come back despite good first treatments. And we know that right now, we are able to cure the majority of people, even when their lymphoma comes back after good treatment. So what I always tell my patients when I meet them for the first time is, as I'm describing the choices that we have together to treat their lymphoma, I say, don't forget that even if things go wrong and your lymphoma comes back, which is not what I hope or expect, but just remember that if it comes back, that is not a death sentence. We are still likely to cure the disease at that point. Cure meaning go away, never come back again, happily ever after the end. That may require a little heavy lifting. It may require a little bit of creativity, but our expectation is still, even if it comes back, that we would and will be able to cure it. So just remember that, so that in those dark nights when you're lying in bed and you're worried about what if this isn't working, that you can remember, no, Matt said that's not a death sentence, and that there's lots of good things that we can do there. That is true now after ASH, just as it was true before, and all the more encouraging. Where's my encouragement coming from in this setting? I've been talking a little about those immunotherapies, and as nuanced as I think we need to be about their use in patients with newly diagnosed Hodgkin lymphoma, because those patients are often cured without such treatments. In patients who have their disease come back after chemotherapy, we know that immunotherapies are very powerful and can really lead to a tremendously greater chance of cure than we had before those treatments were available to us. We're now understanding better how to combine those immunotherapies with other chemotherapy medicines that we traditionally use after first chemotherapies have failed us. And this combination of chemotherapy and immunotherapy for patients when their lymphoma comes back after good treatment is proving to be very powerful, safe, and highly successful at getting patients into remission or back into remission.
That's wonderful. I feel so lucky to be alive in this time in medical science and just accessibility to medicine. And I just think it's incredible. And people like you who are doing the work, us patients, we're so lucky that people are excited about this and interested and have continued to develop the science to help keep us alive.
This is really a global effort. So many smart physicians, scientists, researchers, research professionals, clinical trial nurses. I mean, the amount of work that is being done at the global scale to improve outcomes for patients with Hodgkin lymphoma is breathtaking. And what that means is that the pace of discovery is breathtaking, and our ability to continue to cure more patients safely, effectively, and to restore them back to full health I mean, it's truly inspirational.
I agree. I agree. Any sort of last thoughts that you think are important to relay to patients or caregivers?
Yeah, the last thing I would say is don't be afraid to ask questions. So often I have patients come in and they are overwhelmed, and of course, um, they're just there's so much relief to hear a plan and to hear good news that there's treatment choices and treatment options and that cure is obtainable. That I think that there's a reluctance to want to rock the boat or to advocate for yourself or to ask questions and to learn more. That deference to the physician. On this side of the chair, I don't want that. I don't need that. I would much rather be in a partnership and a conversation. What I tell my patients is that this is not my journey. This is your journey. You're the one climbing the mountain. I'm the Sherpa. I'll drag your bags alongside you, but this is your journey. And I need you to be as prepared and ready, as informed and engaged as possible so that we can do this together. So that means ask questions, learn, satisfy your curiosity, ask the what ifs, understand your risks, understand what your role in this is. How can I improve my outcomes? What can I do to keep myself safe on treatment? What should I do with exercise? What about diet? What about sexual activity while I'm on treatment? How's this going to affect my life? What about work? How do I disclose this to people that I'm dating? All of this stuff, the questions that naturally swarm all of our brains when we're trying to understand this terrible thing that's going on. If you don't ask those questions, you're doing yourself a disservice, and you're not giving your doctor a chance to do the right thing with you and for you. So my one piece of advice is ask questions.
One of my favorite questions that my doctor asked me was, what's really important for me to know about you to take good care of you? And I told him, I love being a mom. I love playing guitar with neuropathy, which is really important. And I love running. And so the lung toxicity, those things are really important to me. So knowing that, just that little sentence was a key part of knowing how to take good care of me, because we watch out for the nerve issues, and we watch out for trouble breathing and things that could really impact my quality of life. So I think that's great.
Sounds like you have a wonderful oncologist.
Yeah, absolutely. Well, thanks so much for being here with us today, and for taking time out of your busy conference schedule to chat with the patient story. We're so lucky.
It's my privilege. There's nothing more important than this piece of things. What we do is about our patients, their caregivers, their loved ones. This is all it's ever about. So the opportunity to share my thoughts with you and to speak with you guys today is an honor.